TopMedTalk. Oh my goodness, Christmas Day. Why do we do this? Oh, yeah, it's pre-recorded, isn't it?
It is.
Nick is in on Christmas Day. Gotcha.
Thanks,
right.
Nick.
Okay, thanks, Nick. So here we are, second part. Happy holidays to everyone. Happy Christmas to those people celebrating Christmas. TopMedTalk is here. I'm Monty Mythen, Editor-in-Chief. This is pre-recorded, actually, if we're being honest.
We are. We're always honest.
And it's pre-recorded where?
In Louisville, Kentucky.
Louisville, Kentucky, at Desiree Chappell's family home. So this is our little walk through the year. We're reflecting on the year in three chunks. We did the same thing last year. Mm-hmm. This is the mid-section of the year. So this is May, June, July, and August. And it sounds as though we do a lot of travelling, which actually we do, but one of our principal objectives is to reduce the amount of travel around the world by allowing as many people as possible to stay at home while we bring them this free open access medical education. But our partners from around the world are starting to send us stuff in while we stay at home, which is good, isn't it?
It is good. It works for everyone. It's a win-win. Yeah.
So, having said that, we're going to have to own up as to where we went first in May of 2019.
Yeah, so we started out at the Society of Cardiovascular Anesthesiologists meeting, the SCA.
SCA, up in Chicago.
Chicago, yeah.
And that was, I was a little bit crestfallen.
Why?
Well, because I was there, but I had to dash off as well to go to London.
It's true.
But a new man joined.
Oh. Well, your seat was taken for a little while. We have some new voices, actually, that have come on throughout the year, but a new anchor and
partner.
One of my partners, our partner in TopMedTalk.
The wonderful
Saul Aronson.
So let's hear that opening clip from Saul.
Welcome to TopMedTalk. We are here in Chicago at the Society of Cardiovascular Anesthesiology's 41st annual meeting. I'm Desiree Chappell, host and managing editor of TopMedTalk, and I'm joined by one of my partners now, Saul Aronson. I'm calling you my partner, Saul.
Now. Good to see you, Desiree.
Good to see you, Saul. Thank you for sitting down with us and hanging here. This is your space.
This is my space.
Yeah, the SCA. You've been around with them for a while, haven't you?
Too many years.
Oh, that's not true.
Too many years.
That's not true. You've been a force, I think, in this organization. So lots of thank yous from a lot of people.
And we are very honored today to have Robert and Shineri. What a lovely name.
Thank
I love
you
that.
so much.
From Temple. Both of you are residents at Temple. Which years?
I'm a CA2.
And
I'm a CA1.
First question I got to get out of the way. Geno's or Pat's?
So, and in that clip, it was clear that immediately he'd managed to find some residents to talk to.
He did. He's great.
It's the SCA. It's the SCA long-running meeting.
Yes.
Cardiovascular anesthesiologists.
Yep.
Saul's been past president, as you said. Loads of great interviews. But what about a couple of highlights for you?
Well, the residents, I think talking to them was a true highlight and a joy for me. We talked a lot about, I think, the papers in the POCI, the perioperative blood pressure papers had kind of come out, and we started talking about those quite a bit.
But I thought we put in the editor's choice, this Sasha.
We did. Sasha Shilcutt, who is an cardiac anesthesiologist, and she actually has started her own, Brave Enough podcast and everything that she does there, Women in Medicine. But we also talked to Tjorvi Perry, who is an anesthesiologist at the University of Minnesota, and we talked to him about burnout.
It wasn't like nothing happened, but I was acting in ways that I didn't like, other people certainly didn't like, and it was directed outward, and so my journey.
Can I ask a question? Was it? Lots of us have been through this sort of thing. Was it how hard you were working, or were you questioning the value of the work you were doing for some people?
That's such an insightful question, because it's not the amount of work, it's not the hours I'm putting in. I probably do the same now, but it got into that self-worth. Like, what if I can't do this? I mean, I could see. We were developing guidelines and trying to implement technology, and I could just see these patients coming through that weren't getting the care that they deserved. And I take it too seriously, or maybe I was too close to it. I just wasn't able to objectify it, and so I took it. I internalized all of it, and now you're living in a chronic state of shamefulness and fear, and the way I pushed away from that was to push people away. And so, so I isolated. I don't think my family liked me very much at the time, and my colleagues, and I own that and I accept that, and but that was part of the journey that now allows me to see things in a different way and appreciate the things that I do, and it was almost a recommitment to medicine. After I came back.
Wow, that's powerful, isn't it?
Yeah, it is. And
so honest.
He is so honest. He's so wonderful to talk to, and just open about his own experiences. And the thing I love about Tjorvi, and I've met him a couple times, is that he's just so thoughtful about everything. You feel like you're really having an open, honest conversation with him. It's really cool.
Now, we speak to some very cool people.
We do.
We got to speak to Charlie Brown.
We did. We did talk to Charlie Brown.
So if you want to know what that really means,
you need to listen to this.
We'll put that clip in the
We'll put a little clip of Charlie
well.
Brown. Yeah.
So what happened next? Left the wonderful Chicago. I love Chicago.
Well,
it's grown on me.
I love Chicago. We've been up there a couple times for meetings this year. But we're
going back in September. It's where it's now the home of EdPom USA.
That's right. I think we're having our annual meeting there every year. So absolutely. I think I said in the last podcast, or the podcast yesterday, but EdPom USA, evidence-based perioperative medicine at USA. Our annual meeting is going to be in Chicago, and it's in September 11th through the 13th, and
a cardiopulmonary exercise training practicum. So you can come and learn how to do cardiopulmonary exercise testing, led by Dr. John Whittle and the team from Duke University Medical Center.
That's right. So check that out. EdPom.org is where you can find that. So we were at the SCA. Be sure to check out, because there were some really great conversations from that. But you had to scoot right out and head to London.
So Anesthesia 2019, the annual meeting of the Royal College of Anaesthetists. Now they've announced where it's going to be next year now. It's actually going to be in Manchester.
Yes.
It's going to be at the football stadium of
I'm
Manchester
so
United Football Club. Now we have these rules about not being able to be at sporting stadia to have meetings when sporting events are on.
Oh, yeah, okay.
Yeah, but you never know what might happen.
I mean,
I doubt it'll be during a match.
I'm highly doubtful, but that sounds exciting.
Exciting for some people, apparently.
Now, we were there last year, and we had it was a very successful. No,
Anesthesia.
With Anesthesia 2018. It was some wonderful conversations we had there.
We missed you. While
this
you
year.
and Sol were hanging out at the SCA.
Don't be jealous.
I went over with Nick and we held the fort. It was the launch of the Centre for Perioperative Care.
Yeah.
Which, if people don't know about that, listen to the podcasts, please. And also get online, the Royal College of Anaesthetists Centre for Perioperative Care. I managed to get Tim Cook together with Paul Wishmeyer for a chat. That was a particularly interesting moment about outcome from emergency laparoscopy. Why don't we just listen to that?
We should listen to that one. It was good.
One of the big national trials that came out recently, a large step wedge cluster randomized trial, trying to look at quality improvement in emergency laparotomy, and the sort of gasp from the audience when the trial results were released appeared to be no difference at all. And then the discussion was it overcomplicated and was it under-resourced? Whereas a lot of this work presented by Carol Peden came out of your institution, you and your buddies there, where you did something and made a huge difference and then networked it. What's going on?
I can't answer exactly what's going on, but I can tell you the Bath story.
Yeah.
So we've had an interest in emergency laparotomy for probably almost 20 years.
And then I think one of the highlights was Nick Majerison did an interview with Hilary Swales about the launch of a new public-facing movie and some other support materials under the guise of Fitter, Better, Sooner. Go for it, Nick.
Nick Majerison here, welcome to TopMedTalk. And on today's TopMedTalk, we've got a conversation with Hilary Swales. Now, she's the lead for patient information at the Royal College of Anaesthetists. And we're looking at the toolkit, the Fitter, Better, Sooner toolkit that Hilary you're promoting. Do you want to tell us a little bit about this, first of all?
Yes, the Fitter, Better, Sooner toolkit was launched last October by the college, and it consists of an animation which is shown often now in pre-assessment clinics or could be shown in GP surgeries. It also consists of one generic leaflet and 6 fact sheets on the 6 most commonly performed procedures in the UK.
That was fantastic. You did a great job, Nick, I have to say. But there's also a link to that little video that you can find in our show notes, too. Super cool.
So my biggest takeaway, because I knew a lot about that stuff with Anesthesia 2019, was when I sat down with Hugh Hemmings. Do you know Hugh?
No.
He's a professor of anesthesia from New York, but he's also the editor-in-chief of the British Journal of Anesthesia. And Hugh talked to us about a topic that worries a lot of us. Do general anesthetics cause neurotoxicity? Let's listen to a clip from that.
Because of the importance of this topic, a number of prospective clinical trials were conducted, 3 of which were reported in the last year. Well, 2 in the last year, 1 in the last 2 years, that looked specifically at the impact of anesthesia and surgery on neurobehavioral measures in humans. And these studies looked at exposure before age 3, which is felt to be the vulnerable period in humans, measured global intellectual function in terms of the IQ test, as well as other secondary measures looking at more specific neurobehavioral tests, and tried to determine whether human infants exposed to anesthesia early would have sustained neurological deficits or neurobehavioral deficits as they matured. Fortunately, all 3 of these studies did not find a positive effect or find a harmful effect on the primary endpoint, which was an IQ. So whatever the effects are, at least in these, given the limitations of these studies, they're not drastic in humans.
So that was London, Anesthesia 2019. Where do we go to next, Desiree?
All right, our next stop was in Vienna, Austria for the European Society of Anesthesiology. We were sponsored through Edwards Lifesciences. We had our own booth there.
Yeah, so
it was huge.
It was great. Largest gathering of anaesthetists in the world, anesthesiologists. Like the ASA, this is the European Society. And there was a cool hangout space there.
There was a little world village of countries, their associations.
And in there, we found a European country we didn't anticipate. America.
The U.S. had a booth
apparently are joining in.
They are. It was really cool. Yeah.
So the American Society of Anesthesiology, we managed to sit down with the president.
We did. We talked to Linda Mason, who was the outgoing president at the time. She was the president last year. And had a fabulous conversation with her about what's happening in the ASA.
It's a pleasure to be here and a pleasure to be at the European Society.
Yeah, so you're here actually because you are the president of the American Society of Anesthesiologists, correct?
That is correct.
Yeah, well, thank you so much for sitting down and taking the time. I know you must be overwhelmingly busy.
Well, there's always time to give information to your listeners, so I'm proud to be here and proud to be able to talk to them.
Yeah, that's fantastic.
That's a big responsibility.
It is.
It is. It takes a lot of time. I live in California, so the travel's challenging because a lot of the things are in the Midwest and the East Coast, but that's part of the job, and there's so many wonderful people to work with at the ASA that it's a pleasure.
Yeah, that's fantastic.
How big's your membership these days? It's a massive organization.
Almost 54,000 members. Almost 54,000. And we're hopefully growing. We have a lot of new initiatives to increase membership. We want to be the source for our anesthesiologists from the time they're in residency to the time they retire.
We also had a chance to sit down with Paul Pomerantz, who is the CEO of the American Society of Anesthesiologists.
And let's see what Paul's got to say.
Yeah.
This is really a great service you're doing for people, giving them a great sense of the conference. The list of podcasts is great, and Linda Mason's is the best.
Yeah, of course. Well, it's great. It's all free open access, Paul, so that's really important to us to make sure that we can get medical education out there to the masses, to really a global audience. And so we appreciate that. That means a lot to us.
And that very much we're part of a big tribe of clinicians.
Yeah.
And providers, payers, patients, we're all in this together.
Yeah.
And that's what we're all about.
Fantastic.
Good stuff.
So ASA have been great partners of ours. Been very helpful in getting us to their major meeting. But I say we'll come back to that in the last third of the year. So once again, inspiring conversation. What's your favourite pick?
So favorite pick from there was, it had to be, we sat down with Maurizio Ciccone from Milan, which I know, I've heard him before. I know you are good friends with him, but it was fantastic. He just was so, just a great chat.
And he's the upcoming president
for ESI.
For the European Society of Intensive Care Medicine.
Intensive Care Medicine, that's right. Yes.
Let's see. So Maurizio, we were talking to him about analytics and artificial intelligence. He had his own
augmented reality.
Let's listen to a little bit of that.
Yeah.
Population will get older, we know that. There's no mystery on that. There will be more comorbidities. That's the success of healthcare. Even the fact that we will see frail patients, probably more than what we see now. I do hope that we will see a change in preventing disease rather than just treating disease, but I'm not sure this revolution will start in the next 30 years. So we need to be prepared to more patients, more complex patients, but I do have hope. I'm doing now quite a bit of research and the work on getting people together, for instance, on working on big data and large data sets. And I do hope that actually that technology could help us a lot, maybe to tailor therapies better. Because I think we're still far away in intensive care from precision medicine.
All right, so Maurizio was my pick. What was your pick from?
Dan Langlois, who spoke to us about nociceptive monitoring, which I knew very, very little about. This idea that now there are monitors, we know, like depth of anesthesia monitors. There are now approved monitors. I'm not sure they're approved in the USA yet, but this particular monitor approved in Europe. That gives us a measure of whether or not we think the patient might be feeling pain during anesthesia. Let's listen to a little bit of that.
We are beginning to accurately and reliably estimate the effects of opioids through the monitors that allow us to measure through the sympathetic-parasympathetic balance the way individual patients would react both to the drugs that we give them and to the nociceptive stimuli that the surgeons supply.
So traditionally, the way we've done it up until now has been the administration of the narcotic type of drugs, the very strong, the morphine type of drugs, on a best guess basis, if we're honest about it. We picked a dose we think is about right. And if the patient reacts in a way that makes us think they're sensing pain, even though they may not be awake and feeling pain, we give more to make those things. So if the heart rate goes up a little bit or something happens, we give more of the drug. You're now saying we can fine-tune that. Is that right?
There's been a shift which came from the drugs. When I started residency in the early 80s, we're having long-acting drugs, fentanyl. And so we were afraid of giving too much opioid dose or concentration, because then you would pay the price, you as a physician, immediately, because you would have emergence which would be delayed. And then, so at that time, the point was underdosing.
Yes.
And this is why we trained at that time that responsiveness to nociceptive stimuli actually are the proof of insufficient opioid concentrations. And then came faster eliminating drugs. So therefore, the price to pay for overdosing was not translated anymore into delayed emergence. It now became translated into altered intraoperative hemodynamics, arterial hypotension. So now the new monitors allow us to look at both sides of the story.
Okay, so always sad to leave Vienna. Where do we go next?
So this was tight. We actually went to ESA and then went straight on to Prato. So I'm going to let you explain what Prato is.
Well, actually, why don't we let Paul Miles explain?
That's a great idea.
This meeting is an invitation only, correct?
That's probably fair to say that. I hesitate to answer that. It's it is not meant to be elitist. It's really a focused meeting for people who are actively involved in clinical trials, particularly randomised trials. But we are very keen to support emerging researchers. We're certainly keen to include potential leaders or site leads of any hospital, pretty well anywhere in the world, even those who haven't done research before. Our only limitation really is around the fact that we are capped at about 120 attendees.
So what an opportunity to sit. I mean, the hard bit was that you're not allowed to tell anyone what we talked about.
It was crazy. And I really didn't know what to expect. I mean, I know you'd been there before, but man, I felt like we were in like the war room or something. You know, I mean, it was just like top secret kind of stuff. So it was super cool.
So very hard to pick some favorites from that.
Oh my gosh.
So I'll let you go first.
Okay, so this is very difficult to pick because I loved every single conversation that we had there because it was just a different format than usual. But one of my favorites was Toby Richards, who is a surgeon from. He was in the UK and then he's down in Australia now.
They coached him because he's such a superstar.
I know, and so I love it. He made his life work anemia in surgical patients, but then it's transferred not only into just surgical patients but women, anemia in women.
So let's hear what he's got to say about that.
So, next question is, can we treat iron deficiency anemia in that setting? And the answer from observational studies is yes. We can use an iron infusion. So 8 years ago, 2 new preparations of intravenous iron came out. These are safe and they enable a total treatment dose up to 1,000 milligrams of iron delivered intravenously in 15 minutes. So that's something that you could feasibly introduce to a perioperative pathway in the future. So we have a problem, we have an intervention, and an intervention that could fit into a pathway. So we took people prior to major open abdominal surgery, so that's people who bleed a lot and spend a long time in hospital with a high morbidity load. And our question was, in 2 weeks prior to surgery, if we give them intravenous iron, do we treat the anemia? As a consequence, does the patient feel better? Therefore, at operation, do they receive less blood transfusion? Post-operatively recover without as many complications and rehabilitate well out to 6 months.
So I know Toby was a favorite, but I have to tell you, Bruce Pickard from South Africa was a favorite, one of my most favorite conversations we've had on Top Med Talk.
So Bruce Pickard, who is a professor from Cape Town in South Africa, has been, with his colleagues down there, been putting together this Pan-African endeavour to understand more about surgical outcomes. Let's let Bruce explain a bit.
Well, the story goes back to 2012, I think, when Monty asked me to talk at a EPOM meeting. And at that meeting, I heard Rupert Pierce present USOS for the first time. And I'm a bit of a nerd, and I like research. And I thought that's something that's possible to do in a resource-limited environment. And so through that, Rupert shared his tools and his protocols. And we ran a USOS-type study in South Africa called SASOS. And then after that, with ISOS, I chatted with Rupert, and we thought we were going to give this a go across Africa, and that was ASOS.
Wow, that was humbling.
Definitely moving.
And I think like the whole, when he gave his presentation, the whole room was hushed in a kind of, hang on a second, these big trials that we're doing are contributing. But that's where the real stuff is going. And what can we do to help that whole endeavour? So we're promised we're going to do our bit.
We are
to go and record more and spread more of the word about the great work that Bruce and his colleagues are doing in Africa. So next, back home, and then
we're back to the States.
Yep.
We were in the ERAS Cardiac Symposium.
Oh, the first, the launch of the relatively recently enhanced recovery after cardiac surgery.
Yes.
So we're lucky enough to do an interview on the stage at a dinner the night before, but then we sat down the following day. They'd had their first workshop, big buzz, well attended, and we sat down with 2 of the leaders there.
Right, Gina McConnell and Judson Williams from Wake Med, who have started this amazing cardiac enhanced recovery program there, and just had a great conversation with them about what they've done and how they've completely changed the face of cardiac surgery. Have a listen.
Of course, we want to showcase Wake Med and what we've done. We're very proud of that, but we wanted to also teach and let other organizations learn from us and us learn from them. I think it was electric in there today. The energy and the enthusiasm from all organizations was awesome.
25 organizations?
That's right, and from all over the country. It'd be nice to have some international programs for the next one, but from California, Maine, Florida, Washington State, and everywhere in between, it was was fantastic. And one of my takeaways was how much I learned.
Yes, we did. We just embarked on this, and we started small and kind of just with the core components of ERAS. And our goal, just barely into the first year, we were like, wow, we have a lot of work to do the prehab portion of it, the readmissions, things that we were talking about. And we've learned from other organizations some things that they have done that they've already implemented different things. So just to come together as a cardiac surgery community and learn from each other, it's awesome.
So, I had my doubts to start with about the need for cardiac enhanced recovery.
You've talked about that,
yeah. But I'm completely convinced now that it makes a big difference. I think part of it is there's a lot more variability in some of the systems around the world. In the USA, for example, than the UK, we've got a relatively small cohesive group, but we can all do better. We can all learn from it.
Absolutely.
So we finish up in the Carolinas. Where next?
EdPom London was our summer.
It's a home. EdPom London, which I say now has been running for a couple of decades, was held in the beautiful setting of the British Museum.
Yeah.
And we had a great setup there.
Oh my gosh. Well, it wasn't just EdPom.
Yep.
So it was in collaboration
with the World Prehabilitation Congress.
Yeah.
So this whole idea of prehabilitation, exercise, nutrition, they joined with EdPom London. They brought their meeting there, and we sold out. What a great gathering.
It was fantastic. And this was only their third year, right? Yeah.
And all of those lectures are available to listen to on all of our lectures are available to listen to on TopMedTalk. But the EdPom London one, every single lecture is up there. Yeah. Free open access. But one of our interviews, you wanted to choose a particular slightly left field one from the EdPom usual discussions.
Yes, one of my favorite conversations, it ties in more to the prehab side of things, but it was Jerry Danjou and Ken Van Someren, and talked to us about how we can tie in some of the things that he's learned through his work and how that ties into surgery. So have a listen.
So Ken and I have known each other for a couple of years, and I was gravitated towards Ken because he's an expert in human performance and exercise science, and I've always had an interest as to how we can translate that into the care for our patients, and I think that's kind of one of Ken's areas of interest. So we're delighted to have you here, Ken, today.
Yeah, thank you very much, Jerry, and delighted to be here. I guess I feel somewhat of an imposter here in this world, but as a sports scientist, most of my career has been around elite performance, so helping athletes and coaches achieve the very pinnacle of their performance. But really all the way through my career looking at how can we take some of those insights and approaches and help the wider population improve, whether it be health, well-being, optimizing their own potential, and currently looking at that across consumer goods, so improving health and well-being in the general population, looking at the workplace as well, how we can enhance employee performance, as well as, of course, the obvious in sports and athletes.
Okay, so we have one other great conversation that we had at EdPom this summer was with another editor-in-chief of a journal, Evan Koresh, for anesthesiology,
who told us all about methadone.
That's right. Have a listen.
I've developed a kind of thinking that we want to match the duration of effect of our analgesic drugs to the duration of pain. Acute postoperative pain is a problem. Surveys among patients have said that 75 to 85% of patients say that their acute postoperative pain was not adequately treated. The majority say that their pain was moderate to severe. We know that pain has significant untoward consequences. Chronic postoperative pain is a problem in 10 to 50% of patients. And the single biggest risk factor for chronic post-surgical pain is acute postoperative pain. Acute postoperative pain also increases the risk of complications like surgical site infections, urinary tract infections, and frankly, patient well-being and patient suffering. So the idea is, as you said, Monty, we really want to try and deliver optimal perioperative pain relief and analgesic care. And so methadone, in contrast to a trend that has developed in anesthesia over the course of the past few decades, towards shorter and shorter and shorter duration drugs, the duration of pain hasn't gotten any shorter. It's only the duration of the drugs. And this is a little bit of a contrarian approach to say that if the pain is going to last a long time, let's use an opioid that lasts a long time.
So are you using methadone in your practice now?
No, actually, no, we have not. I'm compelled to use it, though. I think it's something that this next year I'm going to take a look at.
And so that is the end of episode 2. I hope you've had a wonderful Christmas day. Thank you again to everyone who's working today. Thank you for Nick to coming into the studio to make all of this happen. And
thank you to our sponsors, to our family, our friends. Thank you to all the guests that have come on Top Med Talk and shared their experience, their time with us. And thank you to you, the listeners. Thank you so much.
To those of you celebrating Christmas, happy Christmas. To the rest of you,
happy holidays.
Top Med Talk.